Matthew Holt here with Emad Rizk. Emad is the president of McKesson Health Solutions, which is a big division of a very, very large company. So Emad, to start off with, give us a quick flavor of what the Health Solutions Group does within McKesson.
Sure. Thanks. Thank you, Matt. It's a pleasure to be here. There's three components to McKesson Health Solutions. There's obviously a lot of smaller companies that are within McKesson Health Solutions, but the three large areas are care management, financial management, and clinical criteria. So we'll start with financial management. Financial management is the interaction from a financial standpoint between both payers and providers, whether it's claims editing or contracting or fraud or any types of rules in terms of how their claim systems interact. So that would be the financial management piece. The second one is the clinical decision support, which we have many of our customers are both government, payers, and providers. And again, this is evidence-based. We've been in that business for over 30 years where we pull a lot of the evidence and really publish it. And I think we're known in the country for being the leaders there, especially with CMS and others. And the care management, which is in the old days was called disease management or case management or triage, is really a consolidation of all those where the payers and the providers work together to create a technology and a clinical evidence to be able to manage all the chronic diseases and multiple chronic diseases in the current healthcare system. Fundamental to the three, as you could see when I've described them, is really the payer and the provider working together. I would say that is the fundamental infrastructure and framework that we have in McKesson Health Solutions.
So let's talk about a little about that third one, which is the sort of the interface around consumer disease management, care management. Give us some sense about what some of the newer things you've been doing in that realm have been. These are older established businesses, but you have introduced some new tools in the last couple of years for your payer and provider clients in there. And give us some sense about what in the last couple of years and in the next few years you think are going to be the sort of more important elements of that technology strategy.
Sure, that's a very good question. I think one of the things that the disease management and the care management industry had in the past in terms of struggling was the ROI. I think it did not demonstrate a strong ROI. It was very heavy and clunky. It was not very technologically enabled. I also think it did not empower the consumer or the provider that much. It was almost a parallel process in the healthcare system. So one of the things that we did is we moved back and started to look back at what the fundamentals of care management is. And what we said is it's mainly empowering that consumer, bringing disparate databases, putting it in front of that consumer so that consumer can make the right decision on their healthcare, making sure that that is also visible to the provider. That's that second piece. So the provider is aware of what the consumer is aware. They're giving them the same data. We're feeding the right, correct information to the provider. And third, and most importantly, is we're doing it in a very low-cost, technologically enabled way versus just long one-hour calls with the nurse. So I think those are the three fundamentals of how we change care management for the future.
So talk a little bit about the actual technologies that you think people are using, how you're reaching consumers, what are you investing in, what kind of, I've seen some of the tools you rolled out last year for your health plan customers. Give me a sense of how that's going, the adoption of that, and where you think you're going to get the most bang for your buck in terms of that technology.
Well, I believe that one of the things that we use a great deal is a PHR, but make that PHR a patient health repository. That has to be very well enabled. So we try to feed it with claims, we try to feed it with consumer tools, we have financial tools, financial calculators, we have chat lines with the nurses, we have a library for the patient to be able to access. We have over 3,000 diseases that they can actually access and learn all about them. We can help them with questions when they go to their patient. They can actually send emails to a nurse instead of getting on the phone and calling them. So what we've done is we brought all these tools together to that patient in a very electronic way.
Okay, and give me a sense of the kind of organizations who are deploying that through you.
For right now, it's mostly health plans. We have a very large customer, and that's publicly available at the Federal Employee Program, which is a very large, as you know, and they have 5 million. So we are the sole vendor for that piece. And we get claims feeds on a daily basis from 38 different participating health plans. So that shows you the level of sophistication of that technology. Daily, we get daily claims feeds.
And talk a bit about the adoption of that within the group. I was just at Kai's Spoken this morning. They were talking about how they, took hard work to drive adoption of use of their system. So give a sense about how it's going since you released that a little over a year ago, and how you're working with your partners there to increase adoption of that.
Well, that's a great question, because many people are very enamored by the technology, but others that really understand what the technology is supposed to be is the adoption. So we've been very pleased, and I think FEP has been a great partner. They've promoted the line much better, and I think there's a direct correlation between the organization that believes that this is the right thing to do and promotes it to its consumers or promotes it to its members. I think FEP did that, and the adoption has just been tremendous.
Do you have any data on that? Do you have any metrics on how you...
We do have data. I don't have them directly now, but I know that we have metrics on an ongoing basis, and I believe that when we look at the adoption, we've probably doubled or tripled the metric that we wanted to actually achieve.
Right. So if you give the dogs the dog food, they will eat it if you serve it up in the right way. That's what you're saying.
Yes.
So let's switch to something else, which is, you've been looking at healthcare for a long time. Probably, I think, in the last, year and a half, with the combination of sort of the meaningful use rules, but also now with the stuff that was kind of buried in the Accountable Care Act, but is now coming out, the ACO regs and the changes to Medicare and all that kind of good stuff. Probably you're seeing more changes in the provider side and also on the plan side, the health plan side, than it's been seen for quite some time, maybe forever, I don't know. What do you think, stepping back as an observer of the marketplace, what do you think the real big salient issues are that we need to either grapple with, get right, or are not going to get right in the next 2 to 3 years? What are you most hopeful about, and what are you most scared about? And they may be the same things,
Yeah, well, the most hopeful is that I think that there will be a sharing of tools between payers and providers and an enhanced transparency. So we will not have a black box where claims go in and a lot of clinical criteria, or the providers are working with clinical content that's different from the payer. So what I am hoping, whether it's meaningful use that's going to push interoperability, which is very good, or whether it's going to be the ACOs, which is going to be key processes that will enable a provider to be able to take on risk, both of those are going to require both segments to start to work together and to share. And that is something that I fundamentally believe has to happen in healthcare. We're never going to achieve any sort of this cost and quality and all these altruistic outcomes unless we really get the payers and the providers, the delivery system and the payment system, to somehow become together. So that's on the good side, and obviously that seems a little bit, Pollyannish. But on the negative side is there will probably be a lot of missteps. There will be organizations that don't use all the tools that they want to take on risk and potentially will fail. There will be payers that potentially are not ready to become totally transparent and share some of their tools, and there will be more mistrust in the system. I think that we're going to have a lot of missteps, but we're also going to have some models that are going to be successful.
So there are two things that come up. Both have the word exchange in them, and I think I'd like to get your thoughts about. So one is the insurance exchanges, and the other one is the concept of health information exchange, the health HIE. Let's start with the HIE, the health information exchange, because as you mentioned, insurers, a couple of big insurers have made big bets. Well, United.
Correct.
United keeps on claiming it's not an insurance company, but we'll let them off. They own an insurance company, but they also own Ingenix, which has purchased a large chunk of Axel, and then of course
and then Medicity with that. Yes.
Right, and then more Medicity. And that obviously, looks strategically as though they're now going to get on the path of being more open, but also providing services to providers.
Right.
There's obviously, you talked a bit more earlier about trust, but on the other hand, there are lots of other models for moving data around. There's the indirect model, which, by the way, has been run by one of your sort of colleagues from Aaron Beck from Relay Health, who's seconded to ONC at the moment. So give me a sense of how you think that whole HIE, Health Information Exchange world, is playing out.
Well, fundamentally, you look at the payers and you look at the providers, they sat on different valuable data. They both sat on data, but it was very different. The payers sat on the claims data, and the providers sat on the clinical data. And never the two shall ever meet. Right. And so what I think really the true value, in my opinion, of the HIE is definitely, if you look at all the different layers, connectivity, making sure that you connect hospitals to physicians, hospitals to hospitals, communities together. Yes, those are there. But what I do believe the real end game is going to be to bring a lot of that data together. And I think why a lot of health plans are looking at some of these connectivities is that is a way to get to the clinical data and to the claims data and making sure that you marry them. Because a lot of times you have a lag and the claims data. The clinical data is a little bit more real time. When you look at the clinical data, you really don't have a lot of retrospective review where you can have that from the claims. So I think that the eventual value of the HIE is not necessarily going to be in just the pipe, but it will be in the functionality of that pipe. Your second question around the exchanges, the insurance exchanges, sure. I think those have become a priority for states. And I don't have any specific data, but I have talked to, because we have a large business that's in government.
Sure.
I've spoken to a great deal of those policy creators, and many of them are really looking very aggressively at these exchanges in a very significant way. Some of them are not even waiting till 2014. They're beginning to do this now. They're starting to see the exchanges as a way, in their mind, they're going to lower the entire cost to do business with individuals by creating that 300 to 400 basis points, so 3 to 4% less than what you currently pay for insurance, and you're going to create that plateau just to play. They think that that's pretty significant. So that's the first thing. They're going to give consumers a great deal of choice, and I think that's another one also. And I also think that they're making it so more competitive. So it's not going to be just the health plan that already has dominance in that area. Someone national from another state could actually come and do that. We don't know what the regs are, but it's certainly going to create competition, lower cost, and choice.
Yeah, and do you see some of these ACOs that are forming going sort of direct? I mean, it's a little bit tricky as to whether or not they're insurance companies and how they manage those populations, but you see more and more entities coming onto the exchange?
Well, evidently that's the end game in the ACO.
One would assume it. But
one would assume that that's what they want. That's probably what their consultants are telling them. So if they're able to manage risk, if they could do not just the ACO part, not the accountable care organization part, they could do the accountable care piece. If they can do that, price it, and make sure that they could get on that exchange, they'll be able to get on that exchange. We don't know, again, the regs. Could they get an insurance license? I'm not sure how difficult that'll be, but you are looking at a dynamic shift there, because if you have a provider that has a great presence in that density or in that geography that goes on that potentially is a roundabout way to get to the employer.
Right. Without
using the claims administrative. Then you've kind of made the payer only a claims administration piece. So this is a big deal, I think, for the industry.
Yeah, no, I think it's potentially some really substantial changes, and a lot of the discussion you've had for 20, 30 years about, well, can we cut out that insurance layer, and maybe this is the time we actually can do that, and might see that happening. And you can imagine certain geographies where there's very powerful provider groups, or they've got a wide reach in the network that could actually do that. And you can imagine it both going well and going very badly as well.
Yeah, I think there's a value proposition for almost everybody here. There's a value proposition for physician groups. There's a value proposition for hospitals and integrated delivery system. And there is a value proposition for payers. The question is how each one of those are going to move in a more fluid fashion, and what part of each one are going to come together. Because that's what you see right now is moving. You have a lot of physicians that are either getting purchased by the hospitals, getting ready for an ACO, or forming into these big multi-specialty areas. And you have the payers starting to move, as you mentioned, into the area of providing ACO coverage or ACO support. So you see these lines between these three segments kind of becoming a little more blurred.
Right, last question.
Sure.
McKesson is a huge company, known for drug distribution, gazillion things connected to that. Obviously, the provider technology group services primarily hospitals, but also physicians with information technology, and then your division, and then several other pieces as well. So give us a sense. I think most people argue it's been rather siloed in the way it's operated between those several divisions, and maybe that's the way a big company will be. But given the changes in healthcare, and given that so much of McKesson touches so many pieces of the healthcare system, can you give me a sense of how strategically you're thinking internally about the responses of McKesson to the world? If that's not above your pay grade.
Very, very much so. Very much so. So the first thing I would say is probably McKesson maybe is not as siloed as people think. There's quite a bit. Many of us, the presidents and the EC, the executive committee, come together on a pretty significant basis to really talk about strategy and talk about our organizations and how our organizations come together and what's the value. So we have a lot of what we call one McKesson activities. It just probably is not as visible to the outside world as it is to us. But that being said, we're accelerating all that. We really do believe that the value proposition across both distribution and technology, and within each one of those segments, there are pieces there that when they are linked together, they create 1 + 1 is equal to 3 or 4.
Great. Well, thanks a lot. I've been talking to Dr. Emad Rizk. He is the president of McKesson Health Solutions. Emad, thanks a lot for your time.
Thank you. It's my pleasure.